I'm the principal investigator of the Stop IgAN trial, which is now 10 years ago exactly, and we showed that steroids cause harm and no benefit. And that was all we had in 2015. Essentially, it boiled down to give supportive therapy. There was a RAS blocker, and then we had nothing. Then came the first study with rituximab, and it failed. And we were very disappointed. But what was noted in that study was that despite the rituximab and despite adequate lymphodepletion, the levels of galactose-deficient IgA were not touched. And that was the first indication that maybe it's not the CD20 and CD19 positive cells, but rather long-lived plasma cells, which are CD20 and CD19 negative, but do carry CD38. And that's how this story evolved. And then I guess the first one to come was Felzartamab. And the phase 2 study is now finished, and that has led to some really nice insights. The first one is we've treated patients for 9 infusions given over 5 to 6 months, and then stopped. 1.5 years, no treatment. And that's the remarkable thing. There was a proteinuria reduction. That's no big surprise. Sounds funny, but it's like what everybody else is seeing today. We have 10 drugs under development, and they all have similar proteinuria reductions. But the particular thing with Felzartamab is that the proteinuria reduction persists when you stop treatment, even when you stop treatment for 1.5 years. And my feeling is patients will like that. Patients will like to go through a course of treatment and then don't think about it. GFR loss was pretty much retarded. The downside so far is that if you infuse Felzartamab, it's an IV shot. The first 1, 2, maybe 3 infusions are often accompanied by a cytokine release syndrome because you do destroy lymphocytes and they release cytokines. That can be severe in individual cases. We have now changed the protocol and hope to mitigate that. And in the long run, of course, most companies producing CD38 antibodies go for subcutaneous injections, which really mitigates it because obviously the cell destruction is not all at once, but more prolonged. But that's where we stand. The other truly exciting thing about the phase 2 of Felzartamab is that as you destroy these long-lived plasma cells, all the immunoglobulins go down. But IgM and IgG go right back up to baseline the moment you stop treatment. IgA, for some reason, stays low. And the even more interesting observation, number 3, is that whereas IgA stays low, proteinuria stays low, Gd-IgA goes back. So you can dissociate the treatment benefit from the course of Gd-IgA. That is a potentially important pathophysiological insight because everybody now says that Gd-IgA is what causes IgA nephropathy. I'm not certain about that. And the Felzartamab study is yet another piece of evidence to nurture that doubt. You can stop treatment for 1.5 years, get paid, and that's as long as we got. Maybe you can stop it even longer. The problem is there's no good biomarker. With rituximab, you can monitor CD19 cells and see where they come back. CD38 cells you can't measure in the circulation. That's a downside. So you would probably have to go by IgA level or even proteinuria, which is a very unreliable biomarker. Had this really interesting symposium here covering 3 different diseases where felzartamab is now tested. Membranous, we're just starting a phase 3 study in membranous, comparing felzartamab with tacrolimus, and acute antibody-mediated rejection. And there are some indications that even though we use the same drug in 3 different conditions, the target of the drug is different. In antibody-mediated rejection, there's some evidence to suggest you're targeting NK cells, and they may be the ones which are relevant. And the effect is shorter than in IgA nephropathy. In membranous, we still have to find out. In IgA, you treat the plasma cells, and then you have this long-lasting effect. So it's a very interesting combination. And that may provide a lot of insight into how felzartamab works. But the mere fact that it does work is fascinating. And IgA is only one case where it seems to work nicely. AMR, antibody-mediated rejection, is the first drug we have that seems to work in this condition. It was a disastrous condition so far. Most companies working on CD38 antibodies, as I said, are working on sub-Q formulations so that patients can do it at home. Then they will come in for 9 infusions, but it still means 9 days missed at work. An IV infusion in particular, the first ones where you have to give it very slowly, it simply takes the whole day, essentially. And even though the infusion period itself is short, but you have to come to the hospital, get prepared, etc., etc. It just takes a long time. So if patients can inject themselves at home, that would be a big advantage. And of course, we will have to see the very long-term safety. I'm now talking of 5 to 10 years. And the one thing I really want to see is how safe is it when you have to give repetitive courses of this treatment? Do you come to similar problems as with rituximab? I myself had 2 patients who had gone into persistent hypogammaglobulinemia to the point that we had to substitute gamma globulins after prolonged administration of rituximab for ANCA vasculitis. But that's a pretty disastrous condition, and I hope that felzartamab doesn't, or the anti-CD38s in general, don't have that problem. But we'll have to find out, I guess. The only question I'm being asked all the time is which drug for whom. And I think the drugs of the future are anti-APRIL, APRIL BAFF inhibitors, or CD38 antibodies. Which one of them is better? I honestly don't know. They have obvious differences. The anti-APRILs and the acceps you have to give continuously. CD38 you can have treatment pauses. But in terms of clinical efficacy, they're all pretty similar. And hopefully that will result in competition, and hopefully that will reduce cost. Cost is our big, big issue. And of course, another question that's totally unclear today is, what do you do if somebody doesn't respond well? Can you switch from one treatment to the other? I don't think combination makes sense, but let's say if you fail an anti-APRIL, can you come in with a CD38 antibody or vice versa? We'll have to find out. There's so much to learn. Yeah, very clearly, sparsentan is a great drug. Even if you're on full dose RAS blocker, and we know from real world data, some of which were presented here, that if you're on a RAS blocker and an SGLT2 and you switch the RAS blocker to sparsentan, your proteinuria halves within a week or so. So it must be a hemodynamic effect. It's very impressive. Systemic blood pressure is usually not affected. There's the odd rare patient who has hypotension. And I know from a colleague of mine, Jörg in Stuttgart, that he simply paused the sparsentan for a few weeks and then had no problem restarting it. So it's a great drug in that respect. For us in Europe, the practical problem is if you halve your proteinuria, I cannot prescribe anything else because all these new drugs have a proteinuria threshold of 1 gram per day. Below that, I cannot prescribe Nefecon, for example. It's much better the situation in the US. You can prescribe it if you have IgA nephropathy, full stop, and no other hurdles. So for you, it's easier. But the protection that you get on top of full dose RAS blockade is very nice. And PROTECT was a study which really optimized RAS blockade. And I'm stressing that because my gut feeling is that many studies have said they optimized it, but didn't. We have this really nasty table in a recent Kidney International review on IgA nephropathy where we just compared the placebo or the control groups. They were all on a RAS blocker and had all said we have optimized the RAS blocker. But the annual GFR loss ranged from -1.5 to -15. To me, that suggests that maybe there was still room for improvement with the good old RAS blocker. I'm mentioning that because PROTECT is different. PROTECT demanded that you go on the full dose irbesartan, and 98% of the patients were on 300 milligrams of irbesartan. And when you then switch to sparsentan, you still get a benefit, and a very visible benefit of 1 ml less GFR loss per year. So if you end up with sparsentan at -2.5, despite the proteinuria at which the patients entered, that's a very significant achievement. Unfortunately, only few patients go into full remission with sparsentan. It's a non-specific drug. It's not IgA specific, suggesting that you should probably have a combination of sparsentan plus whatever.